Next, we have Dr. Nagalekshmi Ganesh, and she loves sports, mainly athletics, badminton, and she's into fitness. She's a glaucoma consultant at MNI Hospital, Besanagar, and also a consultant in Dr. Kamakshi Memorial Hospital. So she's going to talk to us about the IOP spike, how to control before, during, and after phacoemulsification. Over to you, Dr. Nagalakshmi.
Thank you, Dr. Nishant. Thank you, AOS, for the opportunity. So we all love to see a pre-op pre-op case like this and a post-op picture like this. However, there are days when we encounter scenarios like these as well, and very often than not, control of intraocular pressure determines the outcome in most of these cases. So my top 5 cents for controlling IOP spike before phacoemulsification, first would be to anticipate red flags. Keep your antennas on when you see glaucomatous eyes, high intraocular pressures, shallow ACs, lens-induced glaucoma, pseudo-exfoliation, short eyes, traumatic cataracts, and when there has been a complicated surgery in the other eye. Always plan to keep the IOP at an optimal level before you proceed with the surgery. When topical anti-glaucoma agents are not sufficient, go and give the patient oral acetazolamide. Usually that takes about 1 to 2 hours to start its effect. Intravenous mannitol takes about 5 to 10 minutes and hence can be used intraoperatively as well. And oral glycerol also has its role in non-diabetics. We also very often come across shallow anterior chambers, and there are various studies which have shown the advantages of early phacoemulsification when compared to laser peripheral iridotomy in these shallow ACs. However, make sure that you always check the post-dilated intraocular pressure in the OPD preoperatively itself, and give instructions not to dilate the patient prior, and prefer to dilate the patients in the theatre under oral acetazolamide or mannitol cover. Also keep a check on the axial length, because very often they have shorter axial lengths, and choose your IOL calculation accordingly. Also make note of the endothelial count and plan OVDs accordingly, because shallow AC increases the risk of endothelial loss as well. And in case you know you're not dealing with a primary angle closure, do a detailed angle study. Use machines like UBM to know the cause for secondary angle closure, because that also sometimes gives cues regarding the zonular status. And counseling and VR backup should be planned accordingly. So as I told you, there are multiple studies which have shown the superiority of early phacoemulsification compared to laser peripheral iridotomies in angle closure, even in acute angle closures and in angle closure glaucomas. However, this does not always hold good, especially when the intraocular pressure is more than 55 millimeters of mercury. The EAGLE group extended the benefits of the phacoemulsification in the angle closure eyes, recommending clear lens extraction in angle closures and angle closure glaucoma. However, we'll have to keep in mind that this cater to a specific set of study population and cannot always be extended to the rest of the population. Though the complications were much lesser in the early phacoemulsification group, these were sight-threatening and had long-term visual implications. So choose your patients for phacoemulsification accordingly. The fourth step would be the decision making to do combined surgery. We all know that advanced glaucomas, patients who are on 3 or more anti-glaucoma medications, they might require a combined trabeculectomy along with phacoemulsification. In cases where the disc view is precluded, like in lens-induced glaucomas, look for the presence of RAPD, which again gives a cue regarding the disc status. In the dawn of mix, mild and moderate glaucomas with cataract, you can combine it with mix as well. Angle closures, goniosynochial can also be combined with phacoemulsification. The fifth important point would be to plan the local anesthesia, because very often we foresee a longer surgery, and hence we might want to give a needle block. However, make sure that you use minimal volume, and if required, supplement by other methods. You can use ocular decompressive devices to keep the IOP less preoperatively, and always check finger tension before you make the first incision. However, if you do encounter a retrobulbar hemorrhage, put off the surgery, give IOP reducing agents, keep a close watch on the vision and the fundus, and the earliest sign of optic nerve ischemia, don't hesitate to perform a lateral canthotomy. Now going on to measures to control intraoperative IOP spikes. we know the long-term implications of high intraocular pressure intraoperatively. When dealing with shallow anterior chamber, always make sure that the preoperative IOP is kept as optimal as possible to prevent sudden hypotony, decompress slowly, and when very often it is also combined with smaller pupils, so use adequate OVDs to keep the anterior chamber pressurized. Don't hesitate to use Ripan Blue, and do a phacoemulsification in the bag or at the level of the iris plane to avoid endothelial loss, and avoid techniques like flip and chip and cartwheeling in the anterior chamber. Also make sure that we keep the anterior chamber formed before placing the IOL to avoid globe distortion. So again, we also very often come across situations like this where iris prolapse can complicate the surgery. So here, while removing the last piece, the patient was complaining of pain and AC shallow. We can see that the iris starts coming out through either of the side ports. I try pushing the iris inside, but it just doesn't go in. Patient is complaining of pain and there is high positive pressure. So step one would be to address all the positive pressure factors, loosen the speculum, use intravenous mannitol, lower the phaco parameters, and address the other positive Valsalva maneuvers, and pray for your best. And here, thankfully, I get away with all these measures and the iris does fall back and I get away without any complications. However, sometimes we might want to take help from the VR team and decompress from behind, do a minimal core vitrectomy before proceeding with the phacoemulsification. So the most dreaded complication happens to be the expulsive hemorrhage, why we all fear the IOP spike. So this very often happens because of a sudden hypotony, which is because of, which causes the choroidal vessels to leak, stretching the posterior ciliary vessels, and thus causing the expulsive hemorrhage. So the risk factors here would be sudden hypotony, Valsalva maneuvers, old age, hypertension, anticoagulants, myopic eyes, prior vitrectomized eyes, and aphakic eyes. So there is an interesting article by the British Journal which showed that most of the expulsives happen following nucleus removal when the globe is distorted. So hence it is important that we always keep the anterior chamber formed at any stage of phacoemulsification. So in case expulsive does happen, then we might want to promptly close the wound, excise prolapsed iris, reduce the intraocular pressure, keep a check on the blood pressure as well, and if we have the expertise, do a choroidal drainage. However, if you want to manage it post-operatively, wait for at least 1 to 2 weeks, follow them with serial ultrasounds, and then plan the choroidal drainage. Now the second situation where the IOP complicates surgery are in lens-induced glaucomas. We might still want to consider phaco in these cases because of the smaller incision and the sparing of the conjunctiva, which offers greater room for trabeculectomy at a later setting if required. And being a closed chamber procedure, the risks of expulsive also remains less. However, the most challenging aspect of managing such cases with phaco would be the performance of a CCC. So we can employ techniques like the fine needle aspiration technique, where we use a 30 gauge needle, bevel down and decompress the lens, aspirate the lens material. We can see the convexity has come down already, the intralenticular pressure is down, and the phaco can be completed with ease after a successful CCC. So also the newer and better machines are available with sensors in the handpiece, active fluidics, which helps in maintaining the pressures, intraocular pressure during intraop. So talking about managing IOP after cataract surgery, high IOP remains the most common post-operative complication. As high as 45% have high IOP of 28 millimeters and more for the first 24 hours. And this is an interesting article which shows that preoperative Diamox helps in bringing down this post-operative IOP spike, which usually happens 3 to 5 hours following a cataract surgery, which even a post-operative oral azithromycin does not address. So as we evaluate IOP spikes post-op, look at the anterior chamber. If there is, the anterior chamber is formed, very often it is a retained viscoelastic which causes the trouble, which can be confirmed by the absence of aqueous currents. and inflammation because of surgical trauma, and air-filled eye, retained lenticular debris, pigment dispersion, hyphema, and infection remains the other causes. Some of the most important causes for late intraocular pressure spike with the deep AC would be steroid response, and sometimes because the foldable single piece IOL in the sulcus can also incite inflammation and intraocular pressure rise. The risk factors for steroid-induced glaucomas are open angle glaucomas, myopic eyes, traumatic angle recession, pigment dispersion. Here we would like to discontinue the steroids or substitute with a non-steroidal agent or with a lesser potent steroid, because the potency has a direct effect on the IOP as well, and that failing might require surgery or laser. When we are looking at shallow anterior chamber and high IOP, very often it is because of the air which causes a pupillary block. We would want to dilate such patients, keep them in supine position, bring the air out, or do a peripheral iridectomy in such cases. And the other important cause remains the malignant glaucoma. The risk factors would be shallow anterior chambers, hypermetropic eyes, angle closure glaucoma, and nanophthalmic eyes. The mechanism is a ciliolenticular block which causes posterior diversion of the aqueous and forward movement of the lens iris diaphragm. So here the management would be medical initially with atropinization. That failing, in pseudophakic eyes we can try a YAG iridotomy and hyalodotomy through the PI or through the capsule. That failing, we might want to intervene surgically by iridozonulo hyalodotomy. So these are two of the cases that we had managed. The first one responded to hyalodotomy, and the second one required iridozonulo hyalodotomy, where we make the anterior and the posterior chamber into one, reducing the pressure difference, and this was also combined with a synecholysis. So the take-home message is always do a meticulous planning preoperatively, prevent intraocular pressure and chamber fluctuation intraoperatively, and probe and manage the cause postoperatively. Thank you for the patient hearing.
Thank you, Dr. Nagalekshmi. Just one question in terms of the mannitol which you give intraop. So we actually give for people who we block. Do we give mannitol, then block the patient, then operate, or we block the patient, then give mannitol, then operate?
Depends upon the preoperative IOP that we are dealing with. If the pressures have not been under control with the maximum topical medication, and we can always check preoperatively, and NCT can always be done. If the pressures are not under control, it makes sense to bring it down as much as possible. So we might want to load the patient with as much as medication as possible to keep it optimal. However, if it is say a shallow anterior chamber and initially to begin with the pressures are not high, we might keep the mannitol as a reserve, because as I was mentioning, the action starts as early as 5 to 10 minutes. So in such cases, maybe we can keep it handy as a backup and then take a call on that.
Thank you.